Margaret was 67 years old, a retired school teacher from Ohio. She walked 2 miles every morning. Rain or shine, hot or cold, she walked. She kept her weight in check. She tracked her numbers. She had been seeing the same primary care doctor for 19 years, the kind of physician who knew her by name, who asked about her grandchildren, who she trusted completely. And when her doctor recommended a procedure, a common one, a routine one, the kind performed thousands of times every single day across this country in hospitals that look perfectly ordinary and perfectly safe, Margaret did not hesitate. Why would she? She had done everything right. She had earned a long life. She trusted the system. She trusted the white coat. She trusted the word routine. She did not make it home from that hospital. Her daughter called me 3 months later. She wanted to know if her mother had been given a choice. She wanted to know if there had been another way. And I had to sit with that question for a very long time because the honest answer was yes, there had been another way. But no one had explained it to Margaret. No one had told her that, after 65, certain procedures that look simple on paper carry risks that most doctors do not have time to fully explain in a 15-minute appointment. Today, I am going to tell you what no one told Margaret. I am going to tell you about 4 medical procedures that seniors are routinely recommended, sometimes pushed into, that carry hidden, underreported, and age-amplified risks. I am not telling you to distrust your doctor. I am telling you to distrust a system that was not designed with your age in mind. Stay with me. My name is Dr. Richard Calloway. I am a cardiothoracic surgeon with 31 years in the operating room. I have performed over 2,400 open heart surgeries. I have held beating hearts in my hands. And I want to say something that most physicians will not say out loud in a public setting. The medical system is extraordinarily good at treating acute crisis and extraordinarily poor at communicating age-specific procedural risk. When a 62-year-old and a 78-year-old present with the same diagnosis, the recommended treatment pathway is often identical. But those two bodies are not identical, not even close. And the difference between them can mean the difference between recovery and a funeral. I have spent 31 years watching the same preventable patterns repeat. I have watched good, careful, compliant patients end up on my table, not because they ignored their health, but because they were never given the full picture. Today, I am giving you the full picture. Here is what nobody tells you. Let me start with something foundational, because without it, nothing I am about to say will fully land. After 60, your body operates on what I call a margin of error system, and that margin is shrinking. Think of it this way. Imagine a suspension bridge that was engineered to carry 20,000 pounds. For decades, it handles that load without a creak. But slowly, year by year, the cables lose a fraction of their tensile strength. The bridge still looks the same. It still functions. You would never know, standing on it, that its tolerance has been quietly reduced. One day you drive the same 20,000-pound truck across it that you always have. And this time, the math no longer works in your favor. That is your body at 65, 70, 75. The architecture is still standing. The systems still function. But the margin for error, the buffer between stress the system handled and stress the system failed, has narrowed in ways that do not appear on routine blood work. Here is what the data shows. Adults over 65 account for 13% of the population, but 34% of all hospital complications from elective procedures. That number is not an anomaly. It is a structural feature of how medicine has been practiced, and it is why you need to know what I am about to tell you. And I want to add something to that picture before we go any further, because I think it will reframe everything that follows. Most people assume that medical risk is linear. You are 60, you are 70, you are 80. The risk increases predictably, like a steady climb. That is not how it works. The risk curve in surgery and invasive procedures is exponential past certain thresholds. Certain biological changes, declining kidney filtration rate, reduced hepatic metabolism of anesthetic drugs, decreased cardiac reserve, attenuated inflammatory response, do not announce themselves on a standard physical. You can look healthy, your cholesterol can be managed, your blood pressure can be controlled, and you can still carry a procedural risk profile that is 3 or 4 times higher than a patient 15 years your junior. The surgeon standing across the table from you may know this. The scheduler who booked your procedure may not have thought about it at all. Let us talk about the first procedure. The first procedure is stenting of stable coronary artery disease. Here is what most people believe. If you have a blockage in a coronary artery and a doctor says we should put in a stent, the natural assumption is that the stent will prevent a heart attack. That belief is understandable. It is also, for a large category of patients, not supported by the evidence. And for seniors especially, this is a conversation that is almost never happening in the right way. A stent is a small metal mesh tube inserted into a narrowed or blocked artery to hold it open. In an acute heart attack, stenting is life-saving. There is no debate there. But the procedure I want to focus on is elective stenting, the placement of stents in patients with stable coronary artery disease who are not having an active heart attack, who are not in immediate crisis. Millions of these procedures are performed every year. And the research, accumulated over more than a decade, including a landmark trial involving over 5,000 patients, has shown something that most seniors are never told. For stable coronary artery disease, optimal medical therapy, the right medications combined with supervised lifestyle modification, produces outcomes equivalent to stenting. The same rates of heart attack, the same survival numbers, without cutting you open. Now here is why this matters even more if you are over 65. The stenting procedure itself carries procedural risks: arterial injury, arrhythmia, reaction to contrast dye, which becomes significantly more dangerous when kidney function has declined, and kidney function after 60 declines in every person, without exception, at measurable rates. There is also the matter of dual antiplatelet therapy. After stenting, you are typically placed on 2 blood thinners simultaneously for a year or more. In a younger patient, this is manageable. In a senior who is already taking other medications, who has a higher baseline bleeding risk, who may fall, this medication protocol carries compounding dangers that can outweigh the procedural benefit. I want to be precise here because nuance matters. If you are having an active heart attack, get to a hospital. If you have unstable angina, stenting may absolutely be the right call. But if your doctor is recommending elective stenting for a stable blockage, ask this question: have we exhausted optimal medical therapy first? Ask for the evidence. Ask what changes in my outcome if we try medications and lifestyle intervention for 90 days before we consider a procedure. Write that down. That question alone could change everything. I have sat in pre-op holding areas with patients who had no idea that question existed. Margaret never asked it. Her family told me that. She trusted the recommendation. She did not know she had options. The second procedure is routine spinal surgery for degenerative disc disease. Back pain in seniors is extraordinarily common. By 65, nearly everyone has some degree of disc degeneration visible on imaging. The disc between your vertebrae, the cushions that separate each bone, lose water content, lose height, lose elasticity. This is universal aging. It shows up on every MRI of every 60-year-old spine, whether that person has back pain or not. Here is what nobody tells you. The presence of degeneration on an image does not mean the image is causing your pain. And the decision to treat what appears on a scan, rather than what the patient is actually experiencing, has led to an enormous number of unnecessary surgical interventions in older adults. The mechanism of spinal surgery for degenerative disease typically involves either removing disc material that is pressing on a nerve, fusing 2 or more vertebrae together to stabilize the spine, or some combination of both. These procedures carry serious age-amplified risks that deserve direct discussion. General anesthesia in seniors over 65 carries a significantly elevated risk of postoperative cognitive dysfunction, a condition that results in confusion, memory loss, and difficulty concentrating that can last weeks, months, or in some cases permanently. The brain, like the bridge in the analogy I gave you earlier, has less margin. The anesthetic agents used during surgery interact with neurological tissue differently in an older brain, and the research on this is clear and consistent and almost entirely absent from pre-surgical consent conversations. Beyond anesthesia risk, spinal fusion specifically carries the risk of adjacent segment disease, the gradual deterioration of the discs directly above or below the fused segment, which now must absorb stress that was previously distributed across a greater length of spine. This means that a percentage of patients who undergo lumbar fusion for one level of disc disease will, within 5 to 7 years, require surgery at adjacent levels. For a 50-year-old, this is a manageable trajectory. For a 73-year-old, the cascade of follow-up procedures is a significantly different proposition. The data on conservative management for degenerative spinal disease is compelling. Physical therapy, specifically targeted core stabilization and nerve mobilization work, has been shown in multiple randomized trials to produce outcomes equivalent to surgery for non-emergency spinal conditions. Epidural steroid injections, used judiciously, can provide meaningful pain relief and delay or eliminate the need for surgical intervention. Pain management strategies that do not involve general anesthesia carry none of the cognitive risks associated with operative care. If your doctor is recommending spinal surgery and you are not experiencing acute neurological emergency, you are not losing bowel or bladder control, you do not have rapidly progressing weakness in your legs, ask specifically what the evidence shows for your diagnosis when conservative management is pursued first. Ask about your anesthesia risk given your age. Ask whether the procedure is addressing what your scan shows or what your body feels. That is not being difficult. That is being informed. Starting tonight, write those questions down before your next appointment. Now I need to stop between these 2 points because what comes next may genuinely surprise you. I have operated on people who successfully refused the first 2 procedures I just described. They pushed back, they sought second opinions, they tried conservative pathways, and then they made a different mistake, a quieter one. A mistake that almost cost them far more than the procedures they avoided. And it involves something that is almost never framed as a choice. Something that looks, when a doctor recommends it, like the obvious, responsible, forward-thinking thing to do. Thousands of seniors walk into this third category every year, feeling like they are being proactive about their health. And they are. But proactive does not always mean procedural. Stay with me. Because the third item on this list is the one I argue about most with my colleagues. And it involves something that looks, on the surface, not like a procedure at all. The third procedure is aggressive early treatment of asymptomatic atrial fibrillation with catheter ablation. Atrial fibrillation, AFib, is the most common cardiac arrhythmia in older adults. By age 70, more than 10% of the population carries this diagnosis. The atria, the upper chambers of the heart, beat irregularly instead of in coordinated rhythm. AFib increases stroke risk significantly, which is why it is taken seriously. And it should be taken seriously. But the treatment approach, specifically the decision about whether and when to pursue catheter ablation, is where seniors are often pushed toward an aggressive intervention before the quieter alternative has been properly tried. I want you to understand something important about how AFib is framed in a typical appointment. The word arrhythmia sounds dangerous. The phrase abnormal heart rhythm sounds urgent. And so when a cardiologist says there is a procedure that can potentially restore normal rhythm, the emotional pull toward that procedure is strong. That is human. That is completely understandable. But the framing omits critical information about what restoring rhythm actually means for your specific situation versus what careful rate management can accomplish and what the procedural risks look like for a person your age. Catheter ablation for AFib involves threading catheters through blood vessels into the heart and using radiofrequency energy or extreme cold to destroy the tissue in the pulmonary veins that is generating the errant electrical signals. It is a technically sophisticated procedure. In younger patients with highly symptomatic drug-resistant AFib, it can be transformative. But here is what the research shows for older adults with asymptomatic or minimally symptomatic AFib. Rate control medication plus anticoagulation, managing how fast the heart beats and preventing clot formation, produces stroke outcomes and mortality outcomes that are not meaningfully different from ablation, with a fraction of the procedural risk. The risks of ablation in seniors include cardiac tamponade, a dangerous accumulation of fluid around the heart that requires emergency drainage, pulmonary vein stenosis, esophageal fistula, a rare but potentially fatal complication where the ablation energy damages the esophagus, which sits directly behind the heart, stroke during or after the procedure, and recurrence. Because in seniors, AFib ablation has meaningfully lower long-term success rates than in younger patients, meaning the procedure may need to be repeated, compounding exposure to each of these risks. Has your doctor discussed all of this with you? Have you been told the specific recurrence rates for patients in your age group? Have you been offered a serious trial of rate control medication before ablation was recommended? If the answer to any of these is no, you deserve better. Ask for the conversation you have not yet had. There is something I need to say to you before I move to the fourth procedure, because I have been carrying it for a long time, and these kinds of conversations are why I started speaking publicly about this. I have stood in operating rooms at 2 in the morning, my hands inside someone's chest, knowing that what I was trying to repair should never have reached the point it did. I have walked out to waiting rooms and delivered news that changed families forever. And in so many of those cases, not the emergencies, not the unavoidable crises, but the cases that were elective, that were scheduled, that were described as routine. The question I could not shake was this: did anyone sit with this person before the first procedure and have a real conversation? Not a consent form, not a brisk walkthrough of risks with a pen pointed at a signature line. A real conversation, with time, with alternatives laid out plainly, with the words, "Here is what you can try first," spoken clearly and without the implicit pressure of a procedure already scheduled on someone's calendar. The family members in the waiting room are almost always the same. They are people who trusted. They trusted the recommendation. They trusted the system. They trusted the word routine. And in a significant number of those cases, there had been another path, a quieter path, a path that did not end in a waiting room at 2 in the morning. That question has stayed with me. It is the reason this video exists. Your heart has been working for you every single minute since before you were born. It has never taken a day off. It deserves decisions made with full information. The fourth procedure is total knee replacement for mild to moderate osteoarthritis in early-stage patients. Knee replacement surgery is one of the most commonly performed elective procedures in the United States, with over 700,000 procedures performed annually. And for patients with severe, end-stage osteoarthritis who have exhausted conservative options, it can be genuinely life-changing. I am not here to tell you that knee replacement is never the right answer. I am here to tell you that it is being recommended, with increasing frequency, to seniors who are earlier in their disease progression than the procedure was originally designed to address. Osteoarthritis of the knee is a continuum. At one end, there is mild cartilage thinning with occasional discomfort. At the other end, bone-on-bone destruction with near-total loss of function. The procedure was developed and studied primarily in the latter group. What has happened over the past 2 decades is a phenomenon called indication creep, the gradual expansion of who is offered a procedure beyond its original evidence base. Patients who are in moderate stages of the disease, who still have meaningful cartilage, who have not yet tried weight management, physical therapy, injections, or bracing, are increasingly being told that surgery is the next step. Here is the age-specific risk picture that matters for you. Total knee replacement requires general or regional anesthesia, both of which carry the cognitive risks I described in the context of spinal surgery. The recovery period, typically 3 to 6 months of meaningful physical limitation, in older adults carries elevated risks of postoperative deconditioning, which can accelerate muscle loss, increase fall risk, and in patients with underlying cardiovascular conditions, trigger events related to prolonged immobility and hypercoagulability. Blood clots, specifically deep vein thrombosis and pulmonary embolism, represent a serious risk in the postoperative period for older adults. What does the alternative look like? The research on structured physical therapy, specifically designed for knee osteoarthritis, programs targeting quadriceps strength, gait mechanics, and progressive loading, shows outcomes at 12 and 24 months that rival surgical outcomes for mild to moderate disease. Weight loss, in patients for whom it is achievable, produces reduction in knee pain that is equivalent in effect size to intra-articular steroid injection. Hyaluronic acid injections, while debated in younger patients, show more consistent benefit in older patients with preserved joint space. None of these carry the operative risks. None require 3 to 6 months of recovery. If your orthopedist is recommending knee replacement, ask specifically which stage of osteoarthritis your imaging shows. Ask whether you have completed a supervised, structured physical therapy protocol, not a few random sessions, but a dedicated 12 to 16-week program. Ask what your recovery timeline would look like given your age, and ask about your specific blood clot risk. These are not hostile questions. Any surgeon who is uncomfortable with them is giving you important information. Let me bring this home for you, because I want you to leave this video with something actionable, not just something frightening. There was a man I will call Thomas. He was 71 years old when he was referred to me for what was framed as an urgent procedure. He had stable coronary artery disease with a blockage in one vessel. He was having no acute symptoms, no chest pain at rest, no significant limitation of daily activity. He came to my office, not because his primary care doctor sent him, but because his daughter, who had watched a video very much like this one, made him seek a second opinion. She had written down questions before the appointment, 3 pages of them. She sat next to her father and asked every single one. And I remember thinking, while she spoke, that this was exactly what the appointment his previous doctor gave him should have looked like. Thomas had not yet tried optimized medical therapy. He was not on the medications that the evidence supported for his specific presentation. He had not enrolled in any form of cardiac rehabilitation. He was being funneled toward a procedure because that was the path of least resistance through a busy system that was optimizing for throughput, not for outcomes. No one had asked him what mattered most to him in his daily life. No one had explained that there was a defined trial period of medication and lifestyle change that had been shown in large randomized trials to produce comparable outcomes to stenting in his category of disease. We started Thomas on the appropriate medication regimen. We connected him with a cardiac rehabilitation program 3 mornings a week. We followed him closely. 14 months later, he is living independently, walking his dog every morning, and he has not had a single cardiac event. He calls my office every year on the anniversary of our first appointment. He reduced his prescription load from 5 medications to 2. His family has him. His grandchildren have him. And he never needed the procedure that was being recommended to him as the only reasonable next step. That is what full information can do. Here is a summary of what I want you to carry out of this conversation. 1. Elective stenting for stable coronary artery disease may offer no advantage over optimized medical therapy for your specific condition. Ask whether you have exhausted non-procedural options first. 2. Spinal surgery for degenerative disc disease carries underreported cognitive and functional risks in seniors. Ask about anesthesia risks and the evidence for conservative management in your specific diagnosis. 3. Catheter ablation for asymptomatic or minimally symptomatic AFib carries serious risks that may outweigh its benefit for older patients compared to rate control medication. Ask specifically about the recurrence rates for your age group and what the evidence shows for patients with your symptom profile. 4. Total knee replacement recommended before conservative management has been genuinely exhausted may expose you to operative risks that outweigh the benefit at your stage of disease. Ask what stage your imaging shows and whether you have completed a structured, dedicated rehabilitation protocol. Not a handful of sessions, but a full, supervised program. Now I want to hear from you. Drop a comment below and tell me, has a doctor ever recommended one of these procedures to you without offering alternatives? What happened when you finally asked questions? Did you push back? Did you find another path? I read every comment. Your experience may help someone else make a better decision. If this video gave you something your doctor's appointment did not, please share it widely. Send it to a spouse, a sibling, a parent, a friend who is navigating any of these decisions right now. Because the information I just gave you should have been freely available at every single appointment, and it is not. That is the failure of the system, not the failure of your physician. And if you are not subscribed to this channel, please do that now. Every week I bring you conversations that the 15-minute appointment cannot hold. You deserve the full picture. It is never too late to start asking better questions. One final word. Nothing in this video replaces the relationship you have with your physician, and nothing here should be used to make a unilateral decision about stopping or starting any treatment. What I have shared today is information, peer-reviewed, data-grounded, and drawn from 31 years at the bedside and in the operating room. Use it to open conversations with your care team, not to close them. The goal is never to refuse care. The goal is to receive the right care, made with full information and made by you. Starting tonight,